Oh man, keep on wasting time. All right, so yeah, I'm thinking because we've done some mock exams. I didn't finish that Boots one. Let me just open Chrome again. Um, I have like a list of things that I keep on getting wrong on the exams. So I think we'll go through that. Um, so is ACS gonna come up if I type that? Warfarin basics, tablet colors, first lines and stuff. All this stuff I think I need to just go through. VTs and DOACs. So I'll go through this. Then what else? We need to go through paracetamol, ibuprofen dosing. Can you dunk? Are you talking about basketball? No, I can't. Oh, actually, can I? I don't know. I've never tried. Well, we have a basketball court, but I haven't actually used it before. Well, I have, but I don't think I've used it to dunk before. I think I was too young. That was when I was like, that was probably like 7 years back. Is it? Yeah, I think my basketball's probably flat by now. I haven't played it for that long. I don't know if I can dunk anymore. Oh, I say anymore. I don't think I did it in the first place. I could shoot. I couldn't dunk at that point in time, so probably not. I don't think I'm tall enough. All right, let's go with this first. Also, we need to go through antidotes. Let's see. So ACS, that's a good one. Antidote. They're gonna be drug toxicity, digoxin antidote, beta blocker antidote, emergency poisonings. So is this gonna have all of them? I think I know most of these. Okay. Um. Okay. Well. We don't have a list for antidotes, which I think we should do. But okay. None of that. What else do we need to know? So we got that vaccines. There are so many different things here, though. I don't know if I'll be able to get through all of these. These are all live vaccines. Could find out which one of those. Flu vaccine. Most people with egg allergy can safely receive flu vaccine. Blah blah blah. Okay. Key stages. Oh, there's a key stage one. Schedule. I need to know this, even though it's so like brain dead. So brain dead. I have to learn. Oh, one other thing that I need to learn is I keep on forgetting it, but contraception stuff. Like I thought I knew it, and then they just add some like random rubbish that I'll forget. I think we could go through the notes I've just already made as well. Let's see. Yeah, we could go through all that. Skin, law, MHRA warnings. MSK. We could go through all the MHRA warnings as well. Okay, I think we'll start with the ACS first because that's a big topic. What's all this? Renal. Actually, let's have a look in the renal folder. What's in there? Renal. CKD staging, AKI sick day rules. Just go through this. There's only 8 guides in here anyway. All right, we'll go to ACS first. Then maybe do this. I think I know most of this already anyway. That's great. Already fell down my pen. Alright, anyway, so let me get the right page. So not this. Warfarin basics and stuff. So slowest is 48 to 72 hours. Bridge with the molecular weight heparin. Dispensing exam point. Goes white, brown, blue, pink. 531.5. How do you bridge? This is the problem. I've got such a small desk that I can't put things everywhere. How to bridge LMH to warfarin. Nice. According to NICE guidelines. So low molecular weight. Heparins are taken for 5 days. 5 days along warfarin. Until... Is this starting it? Yeah, it's from LMWH to warfarin. Until INRs. INR is good. How about opposite way around? Low molecular weight to warfarin. How about warfarin to low molecular weight? So we start it at the same time, continue for 5 days, and in target therapeutic range for 2 consecutive days. Until INR for 2 consecutive days. This is according to NICE. For 2 consecutive days. So that's if you want to go to warfarin. So that's low molecular weight to warfarin. And then opposite way around. Stop the therapeutic low molecular weight. And pre-operative, it should be 1.5 INR. 1.5 INR. So you stop it 3 days before surgery. Stop 3 days. No, stop 5 days before surgery, and then stop for 5 days. Start low molecular weight heparin 3 days. Then 24-hour before stop, and then you need the preoperative one of 1.5. Okay, cool. And then antiphospholipid syndrome and severe renal impairment. So what's antiphospholipid syndrome? Sticky blood syndrome, autoimmune disorder that causes the immune system to produce abnormal antibodies, attack proteins in the blood, making it much more likely to form dangerous clots. Where your immune system attacks proteins in your blood, make your blood clot more easily. So let me just edit this. No, he can't. Why have you on your other account just to say that? I probably can. All right. All right, that's cool. So we're confident with that one, I think. 48 to 72 hours on set. On set. On set. So you can use heparin or low for immediate. For immediate. Anticoagulation. All right. Offer DOAC first. AF stroke prevention. Wait a second. So anticoagulation in AF. Give DOAC first line. And moderate severe mitral stenosis. Moderate severe mitral stenosis, warfarin use. Factor 10A inhibitors, and then dabigatran is direct thrombin inhibitor. direct thrombin inhibitor. Okay. Did I kind of know this already though? Except for this. I'll go with confident because we're gonna. So doxaban, 60 milligram once daily and reduced to. I need to know these because but I always forget them. So doxaban, 60 milligram OD reduced to 30 in 15 to 50 CR cell. Or weight is below 61. Or PGP inhibitor. All DOACs are contraindicated in under 15. So it's reduced to 30 milligram. Edoxaban and dabigatran are twice/once daily factor related agents needing CR based dosing. Why is it saying twice or once daily? What? It just says once daily here? Okay. I don't know about why it says twice, but okay. So done with that one. Swallowed the hole in the original packaging. Never combine two anticoagulants. Label 10. What? Label 10 DOAC. Carry an anticoagulation card. Okay, Roxaban 15 to 20, take with food. Dabigatran swallow whole, do not crush or open. Dispense in the original with the desiccant. Desiccant is the to keep it dry. What's it called? Hygroscopic substance. So desiccant and dabigatran. You gotta keep it in the thing. Original packaging. When warfarin, you do 2 to 2.5. Equals 2 to 2.5 before switching. Dabigatran must stay in its original moisture, protect the packaging, and be swallowed whole. Unstable angina versus STEMI versus NSTEMI. So unstable angina, no cell death. The troponin is normal. NSTEMI, partial obstruction, troponin is raised, no SD elevation. Complete obstruction, SD elevation, and troponin is raised as well. Significant necrosis. All I didn't know was troponin isn't raised. Because it's only ischemia. So troponin normal in angina. I thought it might be a bit raised because I thought maybe like angina causes some sort of death. So troponin normal in angina. I think I should be fine. Aspirin 300 milligram, chewed immediately. Second platelet up to 12 months. So this is after a cardiovascular event. What's the UA? Unstable angina. So if they're already on anticoag, you give them clopidogrel. Okay. So STEMI plus PCI. I just need to remember that what that is again. Is that the percutaneous intervention or whatever? Percutaneous coronary intervention, where you basically use a stent, is it? Yeah. Yeah, it is. Yeah. So if they have a STEMI and have a PCI, then you do aspirin and prasugrel. But if they're over 75, then wait. So STEMI plus PCI. Prasugrel. Over 75. Why are you bleeding? What? Over 75, then maybe others. Then STEMI, NSTEMI plus unstable angina or unstable. Is that UA? It means unstable angina, right? It does. Plus PCI, aspirin plus prasugrel or ticagrelor. So even this is still prasugrel. Clopidogrel is not first line for this one either. And then a second platelet up to 12 months. Wait, which one? In ACS, is aspirin lifelong, isn't it? In ACS, the second platelet is 12 months and aspirin lifelong. Yes. So with the second antiplatelet for 12 months, aspirin lifelong. So what about if on DOAC, then no aspirin and clopidogrel, no aspirin, only clopidogrel for 12 months or lifelong? No, that is not how it's done. When a patient is already taking a DOAC, then aspirin minimized, clopidogrel is used for 12 months, and then clopidogrel is stopped completely. Wait, that's what I literally just said. Then the patient returns to DOAC monotherapy lifelong. Is this according to NICE? Yes, according to NICE, clopidogrel for 12 months. And combining with ticagrelor or prasugrel, then you can't do it. Okay. Should I add something to the do not? Mm-hmm. Do 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 do. Okay. Already on anticoagulant. DOAC. Um. Um. So aspirin is not. Wait, how do I even write this? According to NICE, what happens in peri-procedural phase? In peri-procedural phase, all aspirins, all people get 300 milligram immediately. Enoxaparin. Safely navigate the wires and catheters. So, potent antiplatelets combined with DOAC cause blah blah blah. With a baseline DOAC, the body can tolerate more potent agents. Okay, so without one, okay. Dropped as fast as safely possible, usually within 1 to 7. Stayed at a low dose, at 5 milligram lifelong. What? Okay. Dual therapy, standard adapt, aspirin plus prasugrel thingy. Then DOAC monotherapy. Mm-hmm. So Enstemi plus PCI equals prasugrel or ticagrelor. Or without PCI, just Enstemi. Equals ticagrelor. So basically, if you're having a PCI, then prasugrel. If not, then ticagrelor or cloppy if bleed risk. Okay. Because ticagrelor and prasugrel are potent. Alright, that makes sense. Mm-hmm. If patient is already on a DOAC, potent antiplatelets like ticagrelor or prasugrel are explicitly avoided because combining them with the DOAC causes unacceptable bleeding risks. Okay, I think I know that. 300 milligram chewed immediately, then second platelet up to 12 months. ACS initial management. Also, was my phone vibrating earlier? What's going on? Nothing. I don't know why it's vibrating then. That's weird. Let me just make sure my stocks aren't like flipping falling through the floor. Okay, doing okay now. That's up 3% now. Okay. Mm, this one's going down, down, down. Very dumb. This one's not recovering either. Interesting. Very interesting. Alright, carry on. Initial management antithrombin. Fondaparinux for NSTEMI unless high bleeding risk, immediate angiography, infraction heparin for STEMI plus PCI. So NSTEMI is Fondaparinux and infraction heparin for PCI. So what about NSTEMI and PCI. So pain relief, use GTN, IV morphine, aspirin, antithrombin for STEMI. Let me just search this because that doesn't sound right for the Paranax. For patients with a high bleeding risk, Fondaparinux is preferred and most cost effective. How is Fondaparinux cost effective? I thought low molecular weight would be. If angiography is planned in 24 hours, then use unfractionated heparin. So STEMI, PCI, then unfractionated heparin. So this it's kind of weird because in the summary it's gone in more detail. That's kind of dumb. STEMI plus P. Okay, so for you, unless angiography in the next 24 hours. If the patient high risk bleeding, so high risk bleeding, then it's still UFH as well, isn't it? UFH, yeah. What about renal function? What changes? If high bleeding, then UFH2. Also. What about low molecular weight? Like enoxaparin, is that not used? How is Fondaparinux more cost effective than that? What about NSTEMI plus PCI? Or let's see. Renal function heavily cleared, fully cleared, strictly contraindicated below 30 or below 20 depending on regional guidelines. So what is it then? The 20 or 30? It's so annoying. Renal impairment. Avoid if less than 20. Caution if 30 to 50. So avoid in less than 20. How about enoxaparin? How is that reduced again? Renal impairment. Avoid less than 15 and then reduce it 15 to 30. Enox. Reduce 15 to 30. So everything you have to avoid less than 15. That's good to know. Also reduce dose for these though. So doesn't really say. So 1 milligram instead maybe. So if it's like twice daily, then down to 1 daily. And fraction cleared mostly by energy, it does not accumulate, so therefore EFH is preferred with severe renal impairment. Just heparin. Renal impairment is used with caution. UFH preferred. Renal impairment. So if less than 30, just caution. Okay, that's good to know. Fondaparinux delivers better clinical outcomes, fewer bleeding costs. Treating a major bleed requires blood transfusions, which is incredibly expensive, low mortality, simple dosing, 2.5 milligram once daily, whereas enoxaparin is weight based. Okay, that's good. Fondaparinux is 2.5 milligrams once daily. Okay. Antithrombin choices and STEMI. So we said Fondaparinux for UA and STEMI. So about planned PCI. High bleeding risks. Fondaparinux is preferred over UFH, yeah. Why is it telling me Fondaparinux unless high bleeding? You only choose UFH first if the patient's kidneys are failing. So less than 30. But on here it says avoid if creatinine clearance is less than 30. Okay. Well, it depends. Prophylaxis and treatment. So just avoid less than 20, it says here. Okay. P2Y12 from the Paranux. Okay, but this kind of just confused me. High bleeding risk. Use from the Paranux. What does that mean? GTN spray. N-STEMI, Funparallax, Fraction heparin. STEMI means blood. UFH is the gold standard here because it acts instantly, can be easily monitored, and keeps clots from forming on the surgical catheters. If patients' kidneys are failing, Funparallax will build up in the system and create a severe unpredictable bleeding risk. Therefore, Ghana shifts away and uses UFH. If the patient has N-STEMI but is so unstable that they need immediate angiography, Funparallax is bypassed. So, unless high bleeding risk. So that's what that means. Um. Mm, mm. So I mean that goes on with anything. Mm. Mm-hmm. And then UFH if less than 30. Da-da-da-da-da. What is this? Card initial info. heading um contraindications. Bleeding risks, I'll call it bleeding risks. Okay, save changes. So so okay, so it's a bit weird now trying to learn it. So UFH for STEMI, primary PCI, and Fondaparinux for STEMI. Okay, UFH, interesting man. It's kind of a bit like weird to get your head around. I don't even know how to make notes on this. Oh well. It's just like all over the place. UFH for STEMI, primary PCI. And then FCAT. So unstable angina and then STEMI Fondaparinux. Fonda, then STEMI equals UFH. And then let me try and remember. So STEMI plus PCI is prasugrel, and STEMI plus PCI is prasugrel, and then just an NSTEMI on its own is ticagrelor or clopidogrel if higher bleeding risk. Yeah. If they're over 75, then prasugrel is all. Watch out. Okay, bit of a weird one. Definitely needs review because I don't know how I'll remember that, but it's okay. So use beta blocker for normal left ventricular ejection fraction, and the high intensity statin, and that up to 12 months. So once stable, continue indefinitely. Beta blocker for 12 months. This DAPT. It's not even talking about the rivaroxaban though. I mean, not the rivaroxaban, the DAPA. Aspirin, second platelet, beta blocker, cholesterol, statin. Am I getting confused between two different things? So reduced left ventricular ejection fraction, then beta blocker. no pulmonary congestion. So if LVEF normal 12 months beta blocker, if reduced equals indefinite. I'm kind of confused though. Don't you need SGLT, or is that heart failure only? Yeah, but this is not according to nice guidelines. A, B, C, D, S. So what's A? A is the aspirin beta blocker. C? Or cholesterol. A, B, C. D is... How is D converting enzyme inhibitor? What? Figure out what that means. Star C. Is that the Israel? Is that Jewish? Juicy. Is that it? I don't know. I don't. Maybe I shouldn't be entertaining this. Am I gonna get the Mossad after me if I continue? Yeah, I think that's my final answer. Probably that's what it means. Or is it something else? Yeah. What's ABCDS? That doesn't make any sense. Mnemonic. How does that adapt? Or cholesterol? Or that's why. Because this is the wrong way around. Why is it got cholesterol? There should be converting enzyme inhibitor. A, aspirin beta blocker converting enzyme inhibitor. How many points are on the star? 1, 2, 3, 4, 5, 6. The Star of David only got 5 or something. No, 6. Is that the no, pentagram's 5? 6. C. Is that what you meant to say? I don't know. I have no idea. A, B, C, D, S. Okay, so adapt duration. Until it's conditional therapy. How many C's are there? How many C's are there? Are the 6? The 6 C's. I have no idea. There's the oceans. Atlantic Ocean, Oceanic Ocean. It's different from a sea though, isn't it? Just see how many seas are there. 7. 50. The official 7. Today the expression the 7 seas is figurative. There are 7 major oceanic bodies of water. Yeah, oceans are different from seas. What's the difference between ocean and sea? Ocean versus sea. Oceans are vast, open, deep bodies of water. Salt water, and seas are smaller, typically shallow bodies of salt water. They are partially or fully enclosed by land and are found where the ocean and land meet. Very interesting. Oceans cover about 70% of the Earth's surface. Wow. Yeah, I have no idea how many seas because there's differing answers. But there are 7 oceans. North Atlantic, South. Oh, those are different. I thought Atlantic was like a whole, just one. North and South are different oceans. And Pacific as well has got North and South Pacific oceans. Then the Arctic Ocean and then the Indian Ocean. India owns that ocean. No way. No one else. Atlanta owns the Atlantic Ocean. No way. So with the points of the star and number of oceans. So with the points of the star and number of oceans are six, oh my gosh, 6, 7. Why are you doing this to me? Why? I want to die. Wait, no, that's angry face. How dare you? How dare you? Oh, that's one. Yeah, there we are. Ah. You know what? I'm gonna stay like that from now on, thanks to you. Anyways, where were we? He looks so stupid. Oh man. Alright, ABCDS. So where is it? Nice says nice clinical guidance states that unless there's a clear medical contraindication, all patients discharging with ACS must be on the 5 baseline therapies: beta blocker, ACE, diet, lifestyle, statin. ABCDS. This is completely wrong, man. This is cholesterol here. Where's the thing? Oh. ACE/ARB. So aspirin, beta blocker, ACE/ARB, DAPT. That's the diet and lifestyle. And then statin. High intensity. Atorvastatin 80. Um. All right. So okay, nice says you can add that later once you figure out if they've got any post symptomatic heart failure. Okay. So aldosterone antagonist if heart failure post reduced post MI consider the thingy. Okay. I mean that's okay. Right. Save changes. no reduced. If it's normal, if CI slash no, plus no pulmonary plus no reduced equals CCB. Okay, I think I'll go need for Rui now. Really done with this, to be fair. That's good. GTN, rule of 3. Sit down, take a dose, wait 5 minutes, repeat up to a third dose. No relief 15 minutes after the first dose. 5 minutes after the third. 1, 2, yeah, 5 minutes. This means take 3 spaces. But 1 dose, that means 2 doses, isn't it? But, okay. Wait, let me go and search this. What this doesn't mention is that 1 dose is 1 puff or what 1 spray. So if on first dose you have 2 sprays, then you can only take 1 more. Three in total, or each dose is separate. Each dose, but a single dose can consist of 1 to 2 sprays. So if no relief 15 minutes after the first dose, that doesn't make any sense. It should be 10 minutes, isn't it? 5 minutes, take a dose. 5 minutes, take a dose. 5 minutes. Take a dose. Take a dose. Isn't it only after 2? Or is it after 3? How many sprays maximum can you even have? First dose, you take 2 sprays. Treatment of angina, 1 to 2 sprays to be administered under the tongue and then close the mouth. Dose may be repeated at 5-minute intervals if symptoms are not resolved, up to a maximum of 3 sprays in total. Seek urgent medical attention if symptoms have not resolved after 5 minutes after the second dose. This is confusing me, so because several things are saying different things now. What's the NHS saying? How to take GTN spray. Do not use more than 2 doses during it. So 1 dose is either 1 tablet or 1 to 2 sprays. So dosal spray. Use 1 to 2 sprays under the tongue. If you're still in pain after 5 minutes, you can use a second dose. And 5 minutes after your second dose, pain is still getting worse, then yeah. It's best to have 8 to 12 hours without a patch, otherwise the GTN can stop working over time. So GTN sprays, no, GTN patches. I just want to put that down because I think someone else wants it. So 5 minutes, 1 dose, no, two doses you'll have by then, and then another one at 10 minutes. It would be, wouldn't it? Five minutes after your second dose. That'd be at 10 minutes. So after the dose, 5 minutes. So call 999. Wish. Is that right? Let me ask now. Three sprays total. Okay, so BNF says other things also. I don't know, is BNF... Wait, is BNF different to other guidelines? Or others also say 3 sprays total? Okay, so... Wait, what does this look like actually? Oh, this. Mm, so take care if more sprays per dose. Oh, look at that. Display order 6-7. Why are you making that face? Because you made the flipping 6-7 joke, although I just made it like... Alright, you know what? We'll go back to normal. There we are. I'll take off my glasses because that was phenomenal from you. Alright, anyways. Why is my head wonky? Go back to normal. There we are. There we go. There we go. Fabrizio Romano. Alright. What does it look like if I make the face now? That's better. Anyways. This looks weird without glasses. And it's so weird to see it blinking at the same time I'm blinking. I'm trying to make it blink as fast as possible. Ow, my eyes. Anyways. I'm doing it way too fast. Alright. Anyways. I think I'm confident now with that. Apixaban or Raxaban are first line, if not tolerated. No molecular weight. Oh, this one's a bit hard to remember. CSL 15 no, use low molecular weight or UHF, UFH. Hey, why is it saying no DOX? Use low molecular weight if less than creatinine clearance is less than 15. I swear that was also less than 15. Mashi, do you be profen? They're talking about ibuprofen. Ketaprofen. What profen? Paste. Is this true? I thought avoid molecular hits. Disadvantages: UFH requires continuous infusion, needs frequent monitoring, high risk of heparin-induced thrombocytopenia. Only partially reversible, requires complex anti monitoring. So you need a continuous IV infusion with that one now. Not good, not good. So apixaban or rivaroxaban. Then, if not tolerated, then low molecular weight for 5 days, and then dabigatran or doxaban. Triple positive. Oh, antiphospholipid syndrome. This is good, but it's also missing literally rivaroxaban. How much that is supposed to be? So VT treatment, apixaban and rivaroxaban. Do another card. Dosing info. Highlight card. Call out. Form me a table. Should I do a table? Ooh, pretty good. Rivaroxaban. That doesn't work. Man, I thought that would have been nice. Table rows, and that doesn't even work. I need to fix that. Oh well. Points. Let me just copy and paste this, I think. That would be good. Twice daily for 21 days, then moves to once daily of 20, whereas this one does 10 twice a day, then maintenance 5 milligrams and 2.5. So for extended, does it change after 6 months? Or is that the chosen maintenance dose in the first place? How does renal dosing change doses? How does renal impairment change doses? Dun, 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 dun. Clinical trials such as Amplify X trial for apixaban and Einstein choice for rivaroxaban prove these lower doses maintain clot prevention while drastically reducing long-term risk of bleeding. So for 50, you do standard dosing. 50 to 49, 15 to 49. So 15 to 49, it changes to that. And then this one with, is it 29, isn't it, I think? Yeah, it's 29. The dose does not. This is using different doses, man. This is already wrong. Do it according to nice. Nice. So rivaroxaban. So trying to reduce the dose of apixaban VT. The 2.52 is never used for active acute VT treatment, regardless of poor kidney function. The dosage remains at full strength, 10 milligram twice daily for 7 days, and 5 milligram twice daily. So for VT treatment with renal impairment, the dosing is not reduced. but is cautioned. Hmm. Hmm. Okay. So that's 15 to 49. Okay, so this is to do with VT treatment, though. So let's save this one. New block. Didn't I rename that? I'm sure I renamed that to dosing. Let's change the color as well, might as well. Card info, highlight. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Oh, I don't like it when the racks the bands on top. It picks the band better. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Oh, okay, that was a bit weird. Why did that just make the whole thing reset? Reduce dose or if meet two of the following. Um Do I need to know all the other ones? Doxban Dabigatran. I think I know Doxaban 60 milligram once daily, but it gets reduced to 30 milligram if up to 15 to 50 and below 61. Okay. So that's in AF. It's way less than 61. I'm sure Doxaban 61, not 60. Doxaban. Body weight up to 61. Flipping dumb things. AI, so good, man, so good. Literally just a waste of my time. Stupid, stupid, stupid. This is very annoying. Stays at 150 or 110. Vice Daily. Do, 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 do. Do, 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 do. Do, 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 do. Do, 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 do. Do, do, do. Oh man, I want to my phone keeps on vibrating, bro. What is going on my phone? Why are these randos people asking to follow me? No, I'm not even allowed on that. Who are these randos? Wants to follow you, wants to follow you. I'm not even allowed on social media, so get off. Get off. Desktop raid is on for sale. Oh, that stuff. I just got loads of random Steam things on wish list. On wish list. And so, while enalapril is the standard first line antihypertensive in Black African, then it's nifedipine. First line for breastfeeding generally. Incorrect labetalol is first line for pregnancy. Methadone should typically be stopped within 2 days after birth due to increased risk of postnatal depression. Hydralazine is reserved for critical hypertension, such as severe preeclampsia or eclampsia, not as routine. Hydralazine. Interesting. I wonder if Somalia is a safe place. Like, is it tourist places in Somalia? As such. Are there tourist places in Somalia? Has it got like cool like Islamic architecture over there? So instability. Yeah, bro. UK just says everything's got instability. If Somalia is dangerous, why is it experiencing a surge in tourism? How about Somaliland? Wait, is Somaliland the one that they love Israel? Yeah, forget going Somaliland. Why did they like? Oh, Israel. Yeah, I think I don't want to go now. Alright, and a Dabigatran. I don't know how I'm gonna write about Dabigatran because this doesn't even write anything about it. Should I just write it here? Dabigatran in AF. Let's just talk about VTE. Okay, Dabigatran, AF, and VTE. Is Dabigatran even used in AF? AT should be reduced. And Verapamil as well. Mm. 110. Hmm. So, ow. Oh, man. Nate. Ow. Moderate renal impairment. Then you reduce. Capsules must never be broken. What benefit is a Praxbind? Hmm. It's just with the Verapamil. Um. Kind of want to add to this, to be fair. I forgot how to. Has it already needed 830? Oh, you add it here. Is it inside ACS? There's categories inside. No, you add it in there. In the guides. Yeah, why wasn't that coming in ACS? So? Wait, did I not even notice that maybe there's a Dabigatron one? Andexanet Alpha, Derocuzumab. No specific agent, consider PCC. What's PCC? Protamine sulfate. Prothrombin complex concentrate. Oi. Protamine sulfate for UAFH, Derocuzumab. Andexanet Alpha. So if not tolerated, low molecular weight for 5 days, then Dabigatran or Endoximan. Maybe I should also add something about Dabigatran. Kind of hard to remember everything though. 150 milligram twice daily, or 110 milligram twice daily. VTE. Dabigatran. 30 to 40, no. 150 milligram twice daily. Or so let me just search Dabigatran, BNF, renal impairment. When used for VTE, Needs for treatment of VTE. Consider it. Consider reduced dose of 110 milligram twice daily. If CLCL 30 to 50 ml per minute. Okay. So dabigatran is extensively anticoagulation in AF. And then that one, if for AF, is it what it doesn't even say. Do you not even use it for AF? Is it even licensed? It's not. It's not even licensed for AF. Oh, atrial fibrillation, that one. Cautions. Idarikuzumab. When used for prophylaxis, reduce initial dose, blah 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 blah. And verapamil. Anticoag. See, now I'm kind of like, because now I have to like create whole new topics, and I kind of don't want to. So I'll just leave it. Although someone who this doesn't have everything, then for someone who wants to learn it, but it's fine. And let me just make sure. Did I go through all of ACS? There's one more. VT in cancer and pregnancy. So low molecular weight is thingy of choice. Active cancer. So you do what's 3 to 6 consider DOAC oil. Is anticoagulation choice does not cross placenta. Warfarin teratogenic and DOACs are contraindicated. Continue 6 weeks postpartum. Minimum of 3 months in total. So continue 6 weeks postpartum. Low molecular weight heparin. Okay. Wait 2 to 6 minutes. Oh, anticoagulate for 3 to then review. So if cancer 3 to 6 months. Treatment, treat, review. DOAC/LMWH. Okay, should be fine with that one now. Okay, chat. We went through ACS stroke, VTE, and DOACs, so that's good. This is right about the dabigatran 150. 150 milligram twice daily, or reduced doses 110 milligram twice daily. If you're over 80, or if you have 30 to 50 or 49. Well, 30 to 50, it says right here. 30 to 50. Okay. Reduce. And verapamil as well. I need to write about that. Okay. Should we just go to flashcards? Let me just tick down my list. Should I just ask ChatGPT for antidotes? Because I don't know how the hell I'm gonna go through all of these otherwise. ChatGPT, tell me antidotes for GPHC exam. Go. Acetylcysteine, I know that. Naloxone, I know that. Ooh, flumazenil. Oh, I didn't know that. Benzodiazepine equals flumazenil. So these are antidotes. Warfarin, vitamin K, I knew that. Protamine. I also need to have a look at warfarin, vitamin K. Dosing, but heparin is protamine sulfate. Protamine sulfate. Digoxin is Digitex, I'm pretty sure. Or just is that there? Digitex. Specific antibodies. Deferoxamine, iron. Deferoxamine. Folinic acid, calcium folinate. Cyanide is hydroxycobalamin. Whoa, I didn't know that. Vitamin B12. Hydroxycobalamin, vitamin B12. Methanol. No, I don't need to know that. Octiotride for sulfonylurea. Equals octiotride. Beta blocker. Overdose glucagon. CCB, calcium gluconate, calcium chloride, magnesium, calcium gluconate. Gluconate. Octiotride's the one that I probably won't remember, and fomepizole. Fomepizole? No, flumazenil. Sodium bicarbonate for aspirin. Whoa. TCA, aspirins. Slash aspirins equals sodium bicarbonate. Isoniazid B6, I already knew that one. Physotigmine. Methanol, fomepizole. Ethylene glycol, fomepizole. Atropine. I don't get the organophosphates. Do I need to know that? What the hell is organophosphates? I'm just gonna write it down anyway. And methanol slash ethylene Fomepizole and atropine. So the good ones here that I didn't know was sodium bicarbonate, magnesium has a calcium gluconate, octreotide, hydroxycobalamin, and deferoxamine. Okay, that's good then. So benzodiazepines, I need to know that one. Let me just write these down. So this one, octreotide. The ones I won't remember. I think I wrote down. So yeah, it's flumazenil and octreotide. I think I won't remember. Okay. What's atropine again? Atropine or pralidoxine. Pralidoxine. Okay, so that's antidote. Antidotes done. Vaccines, contraception. Okay, I guess we could go to contraception or vaccines. So boring though, man. What time is it? Nearly 9. Ow. Should I finish that exam that I was doing? Where was that? I think I ended on question 6-7. So stupid. Yeah, I did. I think. I had 1 hour left apparently. Infliximab, ulcerative colitis, no clinical improvement. You stop at week 14. I did not know that. Oh, you just looked at the SPC. Okay, I didn't see that. Um, Moderate to severe active Crohn's disease. Patient does not respond after 2 doses. No additional treatment with infliximab should be given. Available data do not support further infliximab in patients not responding within 6 weeks. Huh? Wait, am I looking at Crohn's disease instead of ulcerative colitis? This is the type of shit that happens in an exam. .1. Whatever, man. Let's just do flashcards then, I think. Then I'll go to do other ones. We'll go to CNS. Let's do CNS flashcards. What treatment should be offered to patients with schizo? So I did this, so I should know. Schizophrenia is antipsychotics, so two second generations, and then one, and then you can try clozapine. No, at least one second generation, then at least one, or or it can be a first generation, and then you can go clozapine and CBT. Look for prolactin, QT risk, sedation. Adverse effects of antipsychotics. Withdrawal, you get the rigidity. Adverse effects. Well, you get like the weight gain. You get like prolactin increase, but I can't remember which one. You get sedativeness. You can get ED. EPS symptoms. What are the EPS symptoms? They are dyskinesia or dystonia. What's dystonia again? Oh yeah. So involuntary muscle contractions. And then what's dyskinesia? Uncontrollable muscle movements. Dystonia versus dyskinesia. What's the difference? Dyskinesia, but dystonia causes prolonged muscle spasms, cramps. Dyskinesia involves smooth, repetitive dance-like or writhing movements. Okay. So you can get dystonia, you can get akathisia, which is restlessness. You get Parkinson's-like symptoms, which are tremors and dyskinesia. And then you can get tardive dyskinesia, which is facial twitching and rolling of the tongue. I just put it in here because I didn't mention anything about postural hypertension, QT prolongation. And I think I said prolactemia and hypoglycemia is in weight gain and stuff. So, what baseline monitoring is needed before starting an antipsychotic? Liver function, renal function. I don't know. Oh yeah, weight and BMI and stuff. Blood pressure. The D2 receptor antagonists, unlike second generation, which can do more. It does more receptors. I can't remember which one, but first generation do D2 specific antagonists, and like haloperidol and prochlorperazine. Yeah, that's how they work. Flupentixol's one. Chlorpromazine, levanpromazine, prochlorperazine, haloperidol, flupentixol. First gen psychiatric disorders, I have no idea. Well, actually, yeah, you get more EPS with those and more withdrawal. Yeah, EPS, hyperprolactinemia. Yeah, because it specifically do block D2 there, more EPS and prolactinemia. Second generation. Um, what's it called? Amisulpride, risperidone, quetiapine, olanzapine. Yeah, aripiprazole. Did I say that one? Clozapine as well. What adverse effects are especially associated with these? Yeah, all sorts like weight gain, which is in aripiprazole. Maybe ED. Um, yeah, all sorts. Um, weight gain, dyslipidemia. My favorite is olanzapine, but it's not as good as I thought. Glucose intolerance and diabetes is a big one. I need to start remembering, but I think I got most of them on. What color can amitriptyline turn urine? I think you can turn it green, rarely. Or blue-green. Or green, yeah. Very weird. What are the risks of prescribing two antipsychotics together? EBS symptoms? Yeah, EBS symptoms. Sedation, metabolic, QT prolongation. Yeah, QT prolongation as well. When is it appropriate after you try two other ones? What is the process for clozapine augmentation with another antipsychotic? Oh, how do you start it? I have no idea. Go grab some croutons as snack. Why do I wait? What have I forgotten what that was? Ooh, a piece of toasted or fried bread, normally cubed and seasoned. Ooh, I kind of want to get some now. Specifically. You mean specifically? Specifically, like the ocean. Mmm, pretty good, man. Ooh, they do look good. Garlic croutons recipe. I kind of want to go eat now. Box croutons from the store. Or olive oil, garlic, shallot herbs, parmesan. White bean salad. What? What even is this? Is this Italian? Why did it just remind me of Italian or something? Who invented crouton? They're French. Practical way to use stale day-old bread. Right. It translates to crust. Used to soak in soup. Traditionally. Interesting. Alright, enough for looking at croutons. Although I'm kind of hungry now. Sent bro on a tangent on some croutons. Yeah, sorry, my mind just goes too much. Anyways, maybe, wait, is this an ADHD symptom? ADHD symptom. Inattention, hyperactivity, impulsivity. Alright, okay, I'm gonna stop looking at that now because that will make it so that I don't have ADHD. Hey, see what I did there? See what I did there? Pretty good, eh? Although I kind of am more curious now. What is the process for clozapine augmentation with another antipsychotic? I don't remember. I think probably like stop it over 4 weeks and probably I don't know. Oh wait, is it like starting it? Like starting it, then you do it weekly for 18 weeks, and then bi-weekly for a year, and then after that you can do it every month. Okay, this is something else. Check it out. Optimize. Oh, you can add a second antipsychotic on top. Hmm. And allow. Okay, well, I did not know that. What are long-acting antipsychotic depot injections used for? Like risperidone, you can use them when they're not non-adherent. Acute, when the person prefers it after an acute episode or when avoiding covert non-adherence. Yeah. What extrapyramidal symptoms can occur with antipsychotics? I went through 4, and I DAPT. So dystonia, which is involuntary muscle spasms. What's the other one? Akathisia, restlessness, Parkinson's symptoms, which is tremors and uncontrolled movements, rigidness, and then tardive dyskinesia, which is like the face twitching and rolling for the tongue. Acute dystonia, muscle spasm, Parkinson's, akathisia, and tardive dyskinesia. Come on, lad. What antipsychotics are most likely to cause hyperprolactinemia? First generation, and I don't know what else. First generation and risperidone, paliperidone, amisulpride. So aripiprazole is prolactin sparing. Aripiprazole, prolactin sparing. I did not know. So aripiprazole seems like the best one. Less weight gain. So aripiprazole, no prolactinemia. And that's good if you don't want to suddenly have breasts. Relatively prolactin. Aripiprazole is prolactin sparing. So that I kind of knew it, but we'll go and review. What symptoms can so you can gynecomastia and ED probably. Yeah. Yep, ED, menstrual disturbance, infertility, galactorrhea, breast enlargement, reduced bone mineral density. I forgot about that one. That's a good one. But I think I mostly knew it, except menstrual disturbance. Well, yeah, that makes sense anyway. Bone mineral density. What antipsychotics are most likely to cause hyperprolactinemia ones? So we said everything except aripiprazole, apparently, really. Haloperidol, haloperidol, risperidone, olanzapine, weight gain, metabolic. What antipsychotics are particularly associated with QT prolongation? First gen? All of them in it. I don't know. I thought all of them. Pimozide and haloperidol. Also be careful with QT prolongation and high doses electrolyte and interactive medicines. So pimozide and haloperidol. Pimozide, haloperidol, QT prolongation. You know what? I don't mind haloperidol as my favorite drug. To be fair, it's not too bad. Pimozidine, or pimozide, first gen antipsychotic. ORAP sounds like oh crap. Okay, I guess I didn't know the classic example, so that goes there. Which second generation antipsychotics commonly cause postural hypertension? Maybe aripriprazole's good run ends here. I think quetiapine and clozapine are safe. Let's see. Oh, the opposite way around. Clozapine and quetiapine are notable causes of postural hypertension. I knew I heard about them somewhere regarding it. Clozapine and quetiapine. But those are the only ones you can start for PDD. Okay. What antipsychotics commonly cause weight gain? Olanzapine and all the other ones really. Quetiapine, except for aripiprazole. quetiapine, risperidone, olanzapine, and clozapine, highest ones. So, olanzapine. Highest risk. Okay. What rare but potentially fatal adverse effect can all antipsychotics cause? NMS, which is when you. But I thought you get that when we drawing, but hypothermia, sweating, rare CK, blood monitoring, LFTs, clozapine levels. Oh, I forgot about that. White cell and neutrophils, yeah. Adverse effects. Neutropenia. Not sure. Neutropenia. Agranulocytitis, neutropenia, cardiomyopathy, seizures. Wow, so many things. Hypersalivation, sedation, postural hypertension, tachycardia, weight gain, blah 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 blah. Constipation can be fatal. Constipation is a big one. Constipation. Yeah, that should be fine. Should we go and review that one? Yeah, the constipation one. What can affect clozapine levels? Inhibitors. Yeah, just inhibitors. Really. Smoking as well. Oh, flip, I forgot that. Infection, inflammation, smoking. Write that one down as well. The infection, smoking. Smoking. What drugs can be used for acute mania, hypomania? So, haloperidol. What's it called? Lorazepam. Haloperidol, olanzapine, quetiapine, risperidone. Short term for agitation or sleep. Okay. Discontinuing. Yeah, that's the EPS symptom. No, EPS, what's it called? NMS. Long-term prophylaxis. Lithium. Important interactions and risks apply to lithium. NTI. Toxic. And says ACE inhibitors, ARBs, diuretics. Yeah, I think I knew all these. Renal impairment, hypothyroidism. I think I sometimes forget that one. Oh no, it can cause hypothyroidism, tremor, GI upset, polyuria, 20% weight gain. I think I'm mostly in all this, to be honest. Lithium levels should be taken. I am not sure. 12 hours after the last dose. 12 hours after the last dose. So basically 12 hours later. So lithium, 12 hours, wait. Point 6 to point 0.8. Maintenance rare thingy, so 0.6 to point 0.8. And 0.8 to 1 for relapse. Okay, chat. I am gonna go and look for some croutons to eat, and I'll be back. Right. I think I'll continue the test later. Or actually, I'll stop doing these. Yeah, I'll stop doing these, and I'll look through my rest of the things I needed to do. So adrenaline, paracetamol, vaccines, and contraception and stuff. And then we'll finish off the test. All right. See you in a bit. I'm gonna go get croutons. No way, it's been 2 hours. Has it actually? Shoot, I didn't know it's been 2 hours. Damn, those croutons are good, but not 2 hours good. What? It's actually been 2 hours. Oh man. One sec, I just need to go put some cream on it. Should I just leave it? I'll leave it for now. Okay, so it's not been taken morning dew. What should happen? Should be taken before the next dose, around 12 hours after the previous dose of the level was missed. Take advice locally. Do not give extra lithium to compensate, and consider holding the dose only if toxicity. Okay, and that was a non-answer. Should I go into something that I haven't looked into yet? I'm just reading through them like briefly, really. Say reading through them, but tamsulosin. I don't want to go do this. Should I just call it early night chat? I just call it early night. I really don't want to do this. I just daydreamed for like ages and then just came back, and now I'm just really not wanting to do this. It's nearly 12 as well. Osteoarthritis, rheumatoid arthritis, andronic, acute gout. How about OTC? What's in here? I really need to go through this, to be fair, though, these ones. Damn, man, you got flipping 4 days left, is it? 4 days? Or 5 days? 5 days? 4 days? This sucks. Earwax. Cold sores. Athlete's foot. Hair loss. I'm so done, chat. What the? Ooh, minor ailments has barely anything in. Okay, so that's not good. Renal, what's in there? That's boring. Special populations. Coding in children. Contraindicated under 12. Displacement volumes. Wise. What's left in CNS? Triptans. What vaccine ones are left? Rotavirus, flu vaccine, COVID, shingles, zoster virus, pneumococcal. 6-in-1. Should I just go through the key stages, I think? Oh, gosh, this is so annoying to remember though. Key stages 8, 12, 16. 8, 12, 16. Men B rotavirus 6-in-1, 6-in-1, 6-in-1. Mm-hmm. 6-in-1, men B, PCV, men B, men B. 1 year. How many 6-in-1 ones do you need? HPV 12 to 13. When you're 14-year-old, TD. Where's the TB ones? You get TB ones? What does that even have in there? It was... What's the 6-in-1 vaccine include as well? Tetanus, pertussis, polio, hepatitis B. Bro, there's so much stuff in this. Pertussis, polio. 8, 12, 16, 1 year, and then 18 months. Okay, let's see what's in endocrine that I missed out. Sulfonylureas. To be fair, it should write on here what the antidote is. What was the antidote again? Start with O, I think. Ocleantride or something. Ocleantride. Oakley. Oh man, what was it? What's the point of writing it down and then I can't even find the flipping page? I've got too many notes. That's a problem to have. Indeed. Oh, I found it. It's octreotride. Okay. Let's see Cappy if he generates anything good. Maybe I'll learn something. I really don't want to do this. Come on, Cappy, generate something good. We'll see. gonna put on my glasses for this because it's gonna be awesome. Control Shift. There we are. Ooh, I want to see if I can buy a Steam Stream Deck. Stream Deck is so similar to Steam Deck actually. Now think about it. Start quiz. Oh gosh. Drowsy at home, empty blister packs, temazepam and amitriptyline. Ooh. GCS9. Somnolent. Spiritual rate of 8. Ooh. That means she needs to go. Flumezanil. Isn't flumezanil a antidote or something? F benzodiazepine, isn't it? Ooh, wait, I just learned about this. Contraindicated because may precipitate thingy. Should be given promptly to reverse benzodiazepine effects. You know, all mixed overdoses? I don't know. It's long acting, therefore preferred. Used when unconscious patients. Can be safely be given chronically. I think to reverse the benzodiazepine effects, that's a good one, isn't it? This is a good question. I don't know. I think this one. Chronic atrial fibrillation takes digoxin 1 to 5 once daily. 3 weeks ago started amiodarone. Oh, nausea, confusion, blurred vision. Ventricular heartbeats. Potassium 5.8. Ooh. What is the single most appropriate immediate management step? Stop digoxin and amiodarone. I think. Ooh, I don't know what the digoxin results gonna be. I probably need to look into that, to be honest. Let me type it. Let me write that down. Ranges for meds. Atriopone, Mr. Calcium gluconate immediately stabilize the myocardium. That one's a good one as well, to be fair. Treat the hyperkalemia now with IV insulin. I think do this one first. Levothyroxine once daily, taken with breakfast. GP starts sulfate and calcium carbonate. You're asked to take these medicines to avoid affecting the thyroid control. This one's a good one as well. I think this needs to be the attends the pharmacy, ongoing nosebleed. What's that called again? I remember learning it. Something access, something like that. It starts with C and it ends with access, I think. He's taking warfarin for atrial fibrillation. Nosebleed. Lean him slightly forward, pinch. Yeah, this one. Ischemic heart disease, oral metoprolol. COPD with salbutamol PRN. Drops for new open angle glaucoma. Yes, but it's safe to start the eye drops. Isn't it brimonidine normally? Salbutamol and metoprolol, an oral metoprolol. Can't prescribe it to recommend a prostaglandin analog instead because topical beta blockers can cause systemic beta blockade and may worsen COPD or cause bradycardia. And combined with oral beta blocker. I mean, he should even be on an oral beta blocker in the first place. H. pylori, lansoprazole, amoxicillin, clarithromycin. Medicines are apixaban and atorvastatin. Which single medic action is appropriate for the pharmacist to take now? He needs to pause his statin. Permanent atrial fibrillation is taking digoxin 125. Cardiologist plans to start oral amiodarone for rhythm control. Oral amiodarone. What is the single most appropriate regarding the digoxin therapy at the time amiodarone is started? Amiodarone is an inhibitor, so reduce the digoxin dose when started and arrange digoxin level. Amiodarone's interaction is delayed by its long half-life. I think this one. Also, presented to the pharmacy 48 hours after onset of painful blistering rash over the right forehead. Ooh, she has got. She needs to go. Because she's got Shingles-Zoster, whatever. Shingles-Zoster virus. Immediate. She needs to go straight to Annie. Which of the following is a legal requirement that specifically applies to prescriptions from Schedule 2 and Schedule 3? They must sign it. It's not a requirement for ordinary prescription medicines. It needs to be written words and figures. Non-valvular atrial fibrillation collects his repeat anticoagulant. It tells you he transfers all his medicines into a weekly multi-compartment aid dosset. Each day because it helps him remember doses. Dabigatran. You can't take that out. Dabigatran, you should keep it inside with the desiccant. Ooh, I got 2 wrong apparently. I got the first one wrong. Flumazenil is contraindicated in suspected co-ingestion of tricyclic antidepressants because it may precipitate seizures and worsen outcome. See, I didn't know that. That one's actually a really good one. Safe for review. Antagonist but can precipitate seizures in patients with mixed overdosing involving proconvulsant agents. Tricyclic antidepressants. It is shorter acting. Is not recommended routinely in mixed overdoses. So what do you give in a mixed overdose? What do you give in a mixed overdose? Mixed benzodiazepine overdose. In overdose, what is the antidote? Specific for benzodiazepine, it reverses the sedative. However, it's prescription medicine. Yep. If benzodiazepines are mixed with other substances like tricyclic antidepressants, flumazenil can trigger severe and uncontrollable cardiac complications. Doctors often rely on supportive medical care rather than using flumazenil, especially in mixed drug overdoses where the exact substances are unknown. Wow, so you just got to put them on oxygen or something. Hyperkalemia indicates major toxicity. Is digoxin causes kalemia to go up? Digoxin electrolyte. Hypokalemia. But then how has the potassium gone up? Does amiodarone increase potassium? No. Does digoxin increase potassium? Yes, it can be. But only in severe overdose. Oh. I see, so it increased it here. Digoxin reported level is unreliable because it sampled 6 hours after a dose. 2 hours after his last dose. Less than 6 hours, okay. Avoid IV calcium and recognize amiodarone increases digoxin concentrations. Avoid IV calcium. I didn't know that. That one's a good one as well. Recommended to separate more than 4 hours. Okay. Sit upright. Because it's anticoagulated, arrange urgent. If bleeding persists, the bleeding is heavy. 5. Timal eye drops are systemically absorbed and cause bronchospasm bradycardia. There are other oral beta blockers, and he also has open angle glaucoma. Erythromycin. Should be individualized with the prescriber. Temporary withholding or switching the statin to one less affected, or seeking anticoagulation device rather than pharmacy unilaterally stopping with anticoagulation. Simply advising the patient to stop. Nope. Okay, so I was supposed to ask the prescriber. Okay, whatever. Reduce it. Therefore, the digoxin dose is usually reduced 30 to 50% when amiodarone is started. And check levels and ECG after 1 week. So save that. That looks like, yeah, Hutchinson sign, yep. And dabigatran should be in there. Cool, that was pretty good. Let's see what the dashboard's saying. Does it say that I've added it? Yeah. It doesn't add it to this. I need to change that. I think it needs fixing. It's broken. I'm gonna call it a night. This is... Yeah, I'm gonna call it a night. I keep on saying I need to get up early, but I just end up not getting up early. And now it's the 11th and my exam's on the 16th. So technically, how many days do I have? 1, 2, 3, 4, 5. 5 more days, basically. Five more days. I've got quite a few things here. I don't know what to do in the next few days. I think I will... We need to go through the notes I've already made, otherwise I'm going to forget it all though. I reckon... we go through OTC definitely. I think we need to go through OTC. What's left in cardiovascular? Amiodarone, warfarin interactions, hypertension, ACE, ARNI, acute heart failure. Should be okay. Nitrate tolerance. Let me just write that one down as well. Wait, what have I got on my sheet left? Yeah, maybe I can do the ones on my sheet first, and then we have to go through all my notes. Okay, we'll do that then. Anyways, chat, it's been good. That's actually a good end though. Kabi actually taught me some good stuff. So yeah, good guy.